Good morning, ladies and gentlemen, and welcome to day 2 of the Colombo Surgical Society, I beg your pardon, the College of Surgeons Sri Lanka Surgical Congress 2021, day 2. We're going to start the session with the expert session for the trainees and all the medical students and the postgraduates who are here today with us. Beginning the expert session for the morning, it's an expert session titled Controlling of Hemorrhage from the Liver. May I invite the chairperson of the session, Professor Rohan Siriwardana, consultant surgeon and hepatopancreatic surgeon from the North Colombo Teaching Hospital, to introduce the speakers of the day and to begin the session.
Thank you very much, and good morning to all of you. Welcome to the morning session, the meet expert session on control of bleeding from the liver. Well, liver has been a feared organ for most of the surgeons. It is gone by, but now things are changing. And to speak about it today, we have two young trainees. Actually, they are not trainees, consultants who are trained in liver. Dr. Prabhat Kumar Singha, who's trained in King's Hospital in hepatobiliary and liver transplant surgery, and Dr. Suchinta Tilakaratna, who is also trained in hepatobiliary and liver transplant surgery. And today we'll be discussing on two areas. First of all, we'll be discussing on bleeding, control of bleeding from during routine surgeries, how to control bleeding from the liver. And next, we'll be discussing on how to control the bleeding during emergencies and trauma situations. So to start, first of all, may I invite Dr. Prabhat Kumar Singha to take you through the control of hemorrhage during routine liver surgeries. Over to you, Prabhat.
Thank you, sir. So first of all, good morning, everyone. I would like to talk on principles of controlling bleeding in hepatic surgery. And the second part of the sessions would be a talk on control of bleeding in liver trauma. So as we all know, liver is a highly vascular organ, and 25% of resting cardiac output is carried throughout the liver. And at a given time, about 1.5 liters of blood stored in the liver. So it tends to bleed. For a hepatic surgeon, bleeding is one of the major concerns, and massive bleeding during a hepatic surgery would give rise to surgical complications, including death. So how can we reduce bleeding in liver surgery? So there are different factors which would give rise to or we should consider when controlling bleeding during liver surgery. So patient factors, there are surgical factors, there are liver and tumor related factors, as well as anesthetic techniques. So control of bleeding during liver surgery starts preoperatively. It's mainly preoperative planning. So if you can see this image, this is a 3D reconstructed image of a liver tumor in relation to its vasculature. This is called a MEVIS software, or there are different softwares that you can create 3D reconstructions. So you can which can give a idea about liver vasculature in relation to certain tumors. So if we can identify the major vascular pedicles in relation to tumors, so we can have an idea when we are going to operate that patient. And the other important thing is liver background and location of the lesion. So if you can see these images in the top left hand corner, you can see a kind of a blue kind of liver. That's a post chemotherapy liver, and on the top right hand corner there's a cirrhotic liver, and downmost is a normal liver. So these are different liver parenchyma, and when we resect, during the resection phase, they behave differently. So basically fatty livers and cirrhotic or fibrotic livers tend to bleed more. And other important thing is presence of portal hypertension and hepatic venous outflow obstruction. So certain tumors which sit on hepatic veins and occlude them, which would give rise to more bleeding because the drainage pathway is blocked, right? And the other important thing is where the tumor is located, whether it's located peripherally. The tumors located in segment 6 and segment 3, which are located peripherally, would be easy to resect because there are no major vascular pedicles crossing the tumor. But centrally placed tumors which are close to hilum or hepatic veins tend to bleed more. And other important thing is, apart from preoperative imaging, intraoperative ultrasound plays a major role for a hepatic surgeon. Then bit about anesthesia techniques. Unlike general surgical procedures, in hepatobiliary surgery, anesthesia plays a major role because during the transection phase, the fluids are not given freely because fluids are restricted and head end of the patient is kept up. The aim of all these maneuvers to reduce the central venous pressure to keep it under 5 millimeters mercury, and it is identified that cable pressure has a direct correlation with the amount of bleeding during the transection phase. So the aim is to keep the central venous pressure low. Then what are the special surgical techniques to minimize bleeding? So as we all know that liver has a dual blood supply which has a hepatic artery, portal vein, and it has an outflow which is drained by hepatic veins. So during the transection we can control the inflow. So it is called inflow control. So inflow control or inflow occlusion, it's a special maneuver, we call it Pringles maneuver. And the other technique is total vascular exclusion. Total vascular exclusion means that you exclude the inflow as well as the outflow. So Pringles maneuver, as we all know, it can be either total or selective. So total means that you occlude the common hepatic artery and the portal vein and you completely exclude the inflow. But we can do this selectively as well. Say if you are doing a right hepatectomy, we can selectively identify the right hepatic artery and right hepatic vein and we can occlude it. So how long should we occlude? So there are different people use different cycles. So we can occlude up to 15 to 20 minutes and we can give a break of 5 minutes, or sometimes you can use 5 minutes Pringles with a 1 minute gap. So it is intermittently used, but this won't completely occlude the liver from its blood supply because there are hepatic veins, so there always can be back bleeding from the hepatic veins. So a bit about total vascular exclusion. As I told you before, you can see it in the picture that you would apply a Pringle as well as you would control the inferior vena cava as well as suprahepatic vena cava. So when you do this, the liver is completely devoid of its blood supply, but the main drawback in this is not every person or every patient can tolerate this because the supply to the heart is reduced. So in special circumstances we can do veno-venous bypass so that the patients can tolerate this total vascular exclusion. Then the other thing is parenchymal transection techniques. So there are different parenchymal transection techniques. The more earlier ones are finger fracture. Using fingers we can crush the parenchyma and identify the vessels, and clamp crush technique or Kelly clamp technique where you use a mosquito or a Kelly clamp to crush the parenchyma and identify the vessels. Then other than that we can use harmonic scalpel, CUSA, water jet, bipolar vessel sealing devices and staplers to control the inflow as well as outflow and the parenchyma. So this picture shows a clamp crush method where you apply a clamp and crush the parenchyma and identify the vessels. So these are mainly used in trauma setting. This is a special machine which is an ultrasonic aspirator which generates ultrasonic energy. There's a vibrating tip which would disrupt the cells which has high water content. So hepatocytes has a high water content and it will be vaporized. But the blood vessels and the bile ducts, they have more connective tissue, so they will be preserved, and then you can securely ligate them or clip them. The other machine that we can use is the water jet, which has a high stream of water which would disrupt the parenchyma and leave the vessels intact. Then another machine that is used is Habib, which generates radio frequency energy, which would coagulate all the parenchyma and small blood vessels and bile ducts. Then later on you can cut the tissue out. So after identifying the small vessels, we can use either bipolar or Liger clips or hemostatic agents to control bleeding. So what are the hemostatic agents used in liver surgery? So there is Fibrilla, Surgicel, Neunit. These are all oxidized regenerated cellulose which would be applied to prevent bleeding from minor venules and capillaries. And Flucil is human thrombin, which also can be applied in certain situations. So as a summary, in liver surgery, preoperative planning is everything, where you find about the vascular pedicles in relation to tumors, and then we adhere special surgical techniques or vascular occlusion techniques and special devices to assist during the transection phase. And hemostatic agents are also used as adjuncts for during the surgery. Thank you.
Thank you, Prabhat. I think we'll have the discussion at the end of listening to both our speakers. The next, Dr. Suchinta Tilakaratne will be discussing about control of bleeding during emergencies or trauma situations. What do you, Suchinta?
Good morning, everyone. So the second part of the talk is mainly on controlling hemorrhage in. Can you see my screen?
Yeah, we can see, yes.
Okay, so second part is on controlling hemorrhage in liver trauma, which is quite frequent occurrence sometimes. So there are basically two problems in liver trauma. One is bleeding. That happens in the initial 24 to 48 hours, and sometimes this can kill a patient. And it's followed by sometimes with bile leaks and sepsis, which are delayed consequences of liver trauma, which can be managed separately. And most of the time, liver trauma is currently managed non-operatively, but for that to happen, there has to be readily available contrast-enhanced CT imaging, and also 24/7 interventional radiological support with regard to embolization and drainage. So generally, out of the liver injuries, grade 1 to 3 liver injuries are generally managed non-operatively. It is in grade 4 to 5 liver injuries that we have to sometimes do operative interventions because they have large liver parenchymal disruptions and also large vascular injuries. So with regard to liver trauma, there can be three categories of patients. Some patients are hemodynamically stable, and we suspect a liver injury because we find free fluid on FAST scan or ultrasound scan. So these patients, we need to do a CT scan to grade the, first identify the liver injury and then grade it, and also to assess for any other intra-abdominal injuries. Some patients are initially hypertensive, but with resuscitation, they become hemodynamically stable. And in these patients also, for the same reasons, we do a CT scan, preferably contrast enhanced. There's another third category of patients who remain hypertensive despite ongoing resuscitation. And in these patients, if we suspect that this hypertension is due to the liver injury, we may have to do emergency laparotomy. But again, in places where they have hybrid theaters and readily available interventional radiological support, we can consider doing hepatic angiogram and embolization before the laparotomy, but that's all based on the available expertise. So if, let's say, if we have to do a trauma laparotomy in a suspected patient with liver injury, it will be based on the principles of trauma laparotomy, and we will do a generous midline incision and 4-quadrant packing, and we have to be always be mindful about associated splenic injuries. And then if we find that there's a large liver laceration which is bleeding, the first step is to manual compression of the liver fragments together. So that will give time for the anesthetic to resuscitate the patient. And also, I think at this point, if we find that it's a large liver laceration, it will be helpful to extend the incision to the right side below the right subcostal margin, so that we'll have better access to the liver. So I have seen some situations where people trying to control bleeding from the liver from a midline incision. Sometimes it can be difficult. And then at this point, if we find that there's a lot of bleeding from the liver, we have the option of packing, perihepatic packing. So the principle is to use minimum number of dry abdominal packs above and below the liver or around the liver in a manner to bring the fragments of the liver together. And also we have to be cautious not to do excess packing or insert large number of towels, which can cause compression of the liver and also compression of the IVC. So the compression of the IVC can lead to reduced venous return to the heart and hypertension, and also it can lead to, on the long run, liver ischemia. Another useful maneuver at this point is Pringle Manual, which Prabhat also talked about. Compression at the portal pedicle will help in reducing the inflow to the liver. This can be done either with a vascular clamp, or we prefer to do with a Foley catheter to prevent crushing of the structures in the hepatoduodenal fold. And after applying the Pringle Manual, if there's still ongoing bleeding, then that means the bleeding is probably from the ruptured hepatic veins or from the IVC. And also, now Prabhat talked about short cycles of Pringle Manual used in routine liver surgery, but in liver trauma, there is evidence to say that even 30 to 40 minutes of Pringle Manual can be safe when we need to control bleeding. And I think at this point, we have to decide whether the patient is stable enough to do further exploration, or whether we are going to do a temporary abdominal closure as part of our damage control surgery with perihepatic packing, where we can revisit the abdomen maybe 24 to 48 hours later and complete the surgery when the patient is quite stable and resuscitated. Otherwise, if the necessary expertise is available and the patient is relatively stable, we can proceed to achieve definitive control of the bleeding. So there can be various methods used depending on the type of the injury. So electrocautery can be used either monopolar or bipolar diathermy in higher settings than we use in routine surgery, to burn the liver tissue, especially in large liver lacerations. This can be used to control the oozing as well as bleeding from small vessels. And if argon plasma coagulation is available, that is also effective in achieving hemostasis from surface bleeders of the liver. Sometimes when there are large vessels, we might have to ligate them, clip them, or suture them. It's preferable to do this while its liver is on a Pringle Manual, because then it will give better visibility. And we can also attempt direct liver suturing with pledgeted blunt tip sutures. Mattress sutures are used, and we avoid excess tension. Generally, these measures are used to control oozing, but it will not help in controlling bleeding from large vessels. So if we don't have a blunt tip suture, we can use the back end of the needle in a reverse pattern as a blunt needle. So also some people use the omentum when there's a large liver laceration. We can use it as we use a Graham patch in peptic ulcer disease, and some evidence to say that there's reduction in infections and ischemia as well. And with all these measures, if still there's ongoing bleeding, sometimes we might have to resort to ligation of the hepatic artery. We prefer to ligate the selectively, either the right or the left hepatic artery, but sometimes there are situations where we have to consider ligating the common hepatic artery as well. So sometimes when the liver, when there are lacerations of the liver with fragmentation of the liver, there are areas of the liver which are devitalized without biliary drainage, without blood supply, and we might have to which are connected to the liver with a small bridge of tissue. We might have to consider resectional debridement. However, some surgeons have attempted anatomical resections of the liver at the time of trauma, but it has shown that it has high morbidity and mortality when you do anatomical resections in a hemodynamically unstable patient taking a long period of time. Sometimes, even with all these measures, still the liver can bleed significantly, and perihepatic packing may not be effective, especially when in situations where there are large vascular injuries. And in these situations, we have to consider total vascular isolation of the liver, where the suprahepatic and infrahepatic IVC is clamped with vascular clamps, and also a Pringle Manual is applied. This can be done for a short period with a view to suture ligate the large vessels that are bleeding. But if there's prolonged time that we have to isolate the liver, then we have to consider extracorporeal bypass as well. And lastly, there are reports of doing liver transplant in situations where the liver is totally fragmented and bleeding cannot be controlled, where total hepatectomy and transplant had been done as an emergency procedure. And however, it has shown that there's reduced graft survival and high retransplant rates compared to the normal transplant procedures in these situations. So in summary, majority of the bleeding from the liver is managed non-operatively with the help of the interventional radiology colleagues. There's need for CT scanning if the patient is hemodynamically stable. And initially we apply principles of damage control, which can be done by any level of training. And then we might have to resort to special techniques if it's a troublesome liver bleeding. Thank you.
Yeah. Okay. Thank you, Sujinta. Well, until we get some questions from our participants, can I ask a few questions from our two panelists? Yeah, I think it was two very concise but excellent two presentations. Both of you all talked about Pringle's Manual. I think it's important, especially for the trainees, how exactly to apply the Pringle's Manual. Do we use, Prabhat said you can use catheter, and you said you can use vascular clamps, but sometimes, especially in the peripheral, you may not get all these, everything that you really require. So how do you actually apply Pringle's Manual? I think it's important for the trainees to understand how to apply, what kind of pressure you apply. Yeah, can we hear from our two speakers about it?
I think first of all, initially we can compress the hepatoduodenal ligament with the fingers at the beginning, if there's profuse bleeding from the liver, and then we might have to create an opening on the lesser omentum so that we can come around the hepatoduodenal ligament, and then I think the best option is to use a urinary catheter, which is readily available at any theater, and then we can bring the urinary catheter around the hepatoduodenal ligament, and then apply artery forceps while applying traction, so that it will compress the hepatoduodenal ligament adequately. So I will prefer rather using a urinary catheter rather than a vascular clamp, because I feel that crushing of the structures can happen in the hepatoduodenal ligament, but vascular clamps are also safely used by other people.
Yeah, Prabhat, what is your preference? Prabhat, are you online?
Yeah. Can you hear me, sir?
Yeah, I can hear. Yes.
Yeah.
We can't see you, but we can hear you.
Yeah, the other
Yeah.
important thing is that we don't do is that once we apply the Pringles maneuver, we have to check whether there is pulse above or the catheter or the clamp you applied. So we have to check manually whether there is pulse above that, so that we have to make sure that there is no flow at all after applying the clamp. So I would prefer to put a catheter or a nylon tape as for a Pringle maneuver rather than putting a clamp.
Yeah, Prabhat, how do you know that how much pressure to apply? You probably what you said was you check for the pulse, and if the pulse is obliterated, then that's good enough. Is that's how you know that you have applied adequate pressure onto the porta hepatis? Is it?
There's I don't know exact value, so
Yeah.
it's mainly I would check
The
the distal pulse.
Yeah. Okay. Yeah.
And also,
Yeah.
one thing to add, I think we have to, at the time you apply the Pringle clamp, you have to get someone to time. Because in this chaos, like you are distracted, you might have the Pringle for a long period and then might later realize that the patient was with the Pringle for a long time. So you have to get someone to time and tell them to tell you at the desired time. Like if you want 30 minutes, tell them that in 30 minutes, tell me, or the time duration.
I think probably the anesthetist is the best person to get the assistance in this situation. Yeah. Okay. So, Prabhat, are there any questions that have come from our participants?
No, sir, I didn't get any questions.
Right. Okay. So, let's say maybe the question is for both of you. Let's say for a young surgeon who's going to start, let's say, a training, who has just completed the senior registrar period, who's interested in liver surgery. What kind of liver lesions they should start their resections with? What is the first? What is your view? What kind of lesions should they start first with?
Can I answer that question, sir?
Yeah, sure.
So I think they should better if they can start from the retrievals, because it would give a chance to mobilize the liver and to get familiar with the anatomy. And so when it comes to routine surgeries, better to start with peripheral lesions like segment 3, segment 6. So you won't make any mistakes, or you wouldn't damage any major structures. So better to avoid structures close to hilum and the hepatic veins. And the first thing I think someone should learn is how to mobilize the liver and apply a Pringle maneuver.
Yeah. What do you think, Sujinta? You agree with that? Or
Yes, I would agree with what Prabhat said. And then I think always nowadays there are many surgeons doing liver surgery. I mean, if you are interested, you can find maybe within 1 or 2 hours, you can travel to a hospital or a center who's doing liver surgeries, and then you can assist in few surgeries before you embark on doing your own resections and all that, so that you can get the opportunity to practice some of these things like mobilization and all that, and also Pringle, applying Pringle and all that, and also to get a assistant or another colleague, so that if you fall into trouble, so your colleague will also be there to help you, rather than doing with the inexperienced another person. And as Prabhat said, retrievals are it's a very good surgery, because you get this opportunity of seeing all the retroperitoneal structures, the liver, the attachments and everything, which you can't see in a normal surgery. So all three I think is helpful if you are considering starting on liver surgery.
Yeah, other worries sometimes, especially you get all these sophisticated instruments like CUSA, maybe water jet, sometimes even harmonic scalpel, especially water jet and CUSA in main centers. And when you start working, when you go to the periphery, you don't get any of these things. So what would you recommend? Because let's say you get a small lesion, and sometimes it is quite unfair for the patient to get to just to resect a small lesion to send them to a faraway specialized place. So what is the method that a starting person can use to resect the liver? What do you recommend?
Can I ask?
Yeah.
I think if you are looking for, if you are going to resect a peripheral lesion, small one, yeah, you can, if you have a small right angle, good retractor, abdominal wall retractor, and some 302 ties, as well as you can use a mosquito as a Kelly clamp. And then with the use of diatomy, both monopole and bipole, I think you can do a reasonably safe non-anatomical resection with those.
Prabhat, what do you think? What is your preferred way of resection to just when you started for small lesions?
So most of the peripheral hospitals have some sort of energy device. So I think we can use either harmonic or bipolar tissue cutting devices. So when we use a harmonic, better to use the lower settings. Like in UK, they have this ultrasonic device called Lotus, which has a very slow cutting compared to harmonic. So even in the harmonic, we can use like 3-4 settings, which are very low, slow cutting. So can be used to resect small tumors.
What is your experience? From both of you, what is your experience on using the diatomy? Because those days, especially when we started, diatomy was we used to use diatomy with the setting. You set up the calculation to around 80 to 100, and then you keep on cutting. So, what is your experience on using the diatomy?
So I think we have very limited experience compared to you. So we have I have used in a couple of instances. So mainly for fibrotic livers and cirrhotic livers, diatomy is better than other vessel sealing devices. And only problem is that it would generate heat and it would destroy. I mean, later on the bile ducts can leak after like few days, because there can be thermal injury. But it's mainly good for fibrotic livers and cirrhotic livers.
And the other thing is about the exposure. That is sometimes another difficult. That is sometimes you struggle. You start even for a small lesion with the midline incision. You can go into trouble when you are not having adequate exposure. What is kind of exposure? Maybe in trauma, maybe in routine surgeries, how do you decide what kind of incision to use to expose the liver? Can I ask it from both of you? Yeah. Any?
So in routine surgery, yeah, Sujinta, go on.
I feel at the beginning it should be a reverse L incision, and then when with experience for lesions on the left lateral sector, you can use an upper midline incision. But generally, even with an experienced person, it's done with a reverse L incision. So that mobilization of the liver and good exposure is a must, because even if the lesion is small, sometimes you might encounter bleeding, and then you might have to get good access, and at that point it might be really difficult to mobilize.
Yeah, Prabhat, what is your idea? How do you get the exposure for the liver? What is your preference?
So mostly reverse cell incision and Mercedes-Benz incisions are used. So those are the commonly used incisions. So have you ever used, have you ever had to cut the diaphragm to mobilize the liver? Larger lesions?
I have not, but I have seen Professor Aloka Patina using once in difficult case. We use midline incision extended upwards, and he needed some more access, and then he had to cut through the diaphragm and into the thorax as well. But I personally have not used. But probably there is extreme instance. You may have to get more access. In trauma, can I ask? In trauma, you start with the midline incision. But sometimes if the access is difficult, what do you think? Is it necessary to extend laterally, or you feel that?
I generally, sir, if there's significant bleeding, especially to the right of the falciform, I would put another incision to the right side subcostally. So it will be really helpful in getting more exposure, and because this is an uncontrolled situation, so you have to have your maximum exposure. So I have seen people struggling just with the midline, and then once you put that subcostal incision, rather a transverse incision below the costal margin, then it helps in giving better access.
Okay. Prabhat, if there are any questions in the chat box, you can just...
Yeah, there's one question regarding the endovascular procedures that can be adhered during liver surgery.
Yeah.
Sujinta, would you like to answer that?
So what's the question?
So endovascular techniques which can be used in liver surgery, say embolization, kind of things.
So it's generally done by the interventional radiologist, not at the time of surgery, but through femoral axis they can lay the aorta and then get into the celiac axis, and then they can selectively, one is embolize tumors and all that, and also in situations of trauma and bleeding, it can be used to embolize the branch that is bleeding selectively. And also sometimes after liver surgery, we find that there's pseudoaneurysms and then bleeding, which also can be, if it's from the artery, can be used with intervention radiologist endovascular procedures. But for bleeding from hepatic veins and the veins, I don't think the outflow, I don't think there's not many options are available. But certainly they can do portal vein embolization and also hepatic artery embolizations.
And Sujinta, one question, like say after liver trauma, do you recommend follow-up CTs, say after 5 days or 10 days?
Yes. We generally, after the initial CT, we prefer to do a CT in about 3 weeks' time, unless there's a special reason to do it beforehand or earlier. But generally, a follow-up CT in 3 weeks' time. Yeah. That is to look for bile leaks that can happen after liver trauma, and also to see that the injury is not causing any other problems.
So, and also like in Kings, when they discharge a liver trauma patient, they would do a CT in 5 days to check whether there's any pseudoaneurysm formation. So usually as a routine, at day 5, a CT is being done to exclude any aneurysms.
Prabhat, is it done for all the patients, or does it depend on the initial injury that the patient had? Or
no,
is
sir,
it,
all the patients, whatever the liver trauma, they routinely do a day 5 CT scan before discharge.
Okay. Yeah. Can I just ask another question now? This is about trauma. I think important, sometimes the difficult decision to make is when to open up, when to open a patient's abdomen when you're only thinking of liver laceration. How do you make that decision? When to open? How far can you stretch without opening the abdomen?
So it will depend on basically 2 factors: the hemodynamic status of the patient, and with initial transfusions, and if you feel that you are achieving some degree of stability, you can delay the opening. And also the other thing is the availability of CT scans and also the interventional radiological support. So if you feel that despite resuscitation, patient is slightly stable but still not proper, the bleeding is ongoing, you can consider a hepatic angiogram and see whether there's any active bleeding from a branch of the hepatic artery. And if all those measures fail, only that you may resort to opening up in a patient who's relatively stable hemodynamically.
Does that decision depend on the degree of injury or the stage of laceration or the extent of laceration that you see in the CT, or is it purely based on your clinical assessment? What is your view?
Sometimes what I've seen is even some large lacerations, they can be, the patient is surprisingly can be stable. And if the hemodynamically stable, and if there's a clot that forms inside the laceration, and that first insert is not an issue, then the problem is going to be bile leaks and sepsis, which can come later again. Then you can use guided drainage and all that. So in the initial stage of trauma, if the patient is hemodynamically stable, I think you can defer surgical intervention.
Yeah.
So what is your experience on this?
Yeah, but Prabhat, what do you think? What is your view?
Yeah, so I mean, when we were in UK, I think none of the patients were opened up for a liver laceration because their interventional radiology is quite good, and so almost all the patients who are hemodynamically stable were interventional radiologically managed. But I think we opened up one patient who came very unstable, and I want to tell you that because one of the surgeons has packed with about 15 packs, and the liver was the inflow was occluded, and that patient had a severe ischemic injury to liver. So when we are applying packs, we have to be very careful to use minimum number of packs and use them in correct location, not to occlude the inflow outflow of the liver.
Yeah. Okay, so that also brings to another important question. Now, after packing the liver, you all described how to pack the liver. How do you monitor that a patient after packing the liver? What parameters do you monitor? Prabhat said it's important that you don't pack too tightly because it can cause ischemic injury. So after packing, how do you monitor?
We generally prefer to monitor the bladder pressure as well, and also the ongoing renal functions, urine output, and also those will be indirect evidence of raised intra-abdominal pressure. So if you feel that there's raised intra-abdominal pressure, we might have to go in early and think of pack removal early. But otherwise, depending on the clinical picture of the patient, within about 24 to 48 hours, we prefer to go in again when the patient is fully resuscitated, quite stable, maybe in an elective setting in a good theater with proper assistance. We might go back again in about 24 to 48 hours. So during that time, patient should be in ICU, should be monitored for raised intra-abdominal pressure with blood pressure monitoring in our setting.
Okay. Prabhat, anything?
So I want to ask this from you. Actually, say now we encounter liver laceration in periphery, and we pack the patient and we control the bleeding. So should we transfer the patient to a major center to unpack?
I think that's another next question I wanted to ask. Well, I think it's an important decision to make whether to transfer the patient to a specialized center or not. I think what is most important is to have a chat with once you have packed and got the bleeding under control. It's good if you have a chat with a place where liver surgeries are done and discuss with the team and basically to discuss about what extent of injury that the patient had and how much of bleeding patient had initially and how stable this patient is to transfer. So considering all these, I feel that if the initial laceration was something that possibly might settle with packing, I think it's okay to remove the packs. Not okay, it's reasonable to remove the packs then and there in the same original place and see whether the patient bleeds again. But if the initial injury is extensive one, involving the hilum or maybe major venous injury, one of the main hepatic veins are injured, and in a situation like that, probably I think it's best that the patient is transferred to another center where the liver surgeries are done, and probably even the original surgeon can go and work with the place that the patient is going to be transferred and remove the packs in a specialized place because then you can do more things. But of course, I think you can remove the packs after 24 to 48 hours in the original place and see whether it bleeds again, and then repack and transfer. That's another option that you can have. That's what I feel. What do you think?
So what about, so do you have to mobilize the liver before packing, or you should not mobilize the liver?
Okay. So what do you think, Suchinta? What is your view?
So what they say is, dividing the falciform and mobilizing will not help in packing. So it'll cause, if it's not mobilized, there'll be compartments which you can pack and then create adequate pressure.
Yeah.
So I think at the initial time, if you're going to just pack and not to do anything else, I think you don't need to mobilize the liver.
Yeah, my view also is it is not essential to pack. The idea of packing is to close the book, apply pressure on two directions, so that the split is approximated and you're applying adequate pressure to stop bleeding. It's mainly venous bleeding that you get in the liver. To achieve that, it is not essential to mobilize the liver, but if you mobilize too much the liver, then actually it's difficult to pack. For example, if you completely mobilize the liver up to the IVC, you have to apply more packs to pack from top end, bottom end, probably a little bit on the side as well. So it is not necessary, I think, to mobilize the liver fully. It's all depends on the type of laceration that the patient is having. And to achieve the maximum pressure on either side of the laceration, you then and there decide how much to mobilize. That is what I think. What do you think, Prabhat? What is your view?
Yeah, I also think not to mobilize because then it will be easier to pack.
And other question is, I can remember once, I think Prabhat, you were also there. We packed the patient a couple of times. Patient started bleeding again, and then eventually a patient died, young patient. How do you decide? When do you decide? Now, when to stop packing? I know. Am I going to keep on packing? Am I going to keep on doing something? Am I going to explore and suture? So how do you think that decision can be taken? What is the cutoff point? What extent or when do you change your strategy? Any views? Prabhat, Suchinta, what do you think?
So what I feel is packing is a way of buying time and getting ready for a definitive procedure. So if you pack once and then at the second time, like after 24 to 48 hours, where you go in with the resuscitated patient in good setup, in a good proper theater with facilities, good anesthetist, blood products and everything, I think if the patient is stable and there are no other injuries, no significant other injuries, I think that may be a case of going for definitive control of bleeding. So you might have to mobilize the liver, get control of vascular pedicles, maybe short period of total vascular exclusion if you think there's a lot of bleeding, and then get definitive control rather than packing again if you are in a proper setup. Like if you feel that you lack something, you may pack again to get that factor corrected. But otherwise, I think after the initial packing, second time is mainly for definitive procedure.
What do you think, Prabhat?
So I think so now when we pack and if the patient is still bleeding, probably there's a IVC injury or Aval's right hepatic vein. But even then, it can be controlled with packing. If it is not, then we have to do a trauma right hepatectomy, which is very difficult in certain situations because these patients are highly hemodynamically unstable, and even doing a cable clamping would this patient won't survive. So I think it's a very fine decision that we have to take, and maybe in highly specialized centers this can be done, a trauma hepatectomy while the patient is bleeding.
I think it's quite a difficult task to do a right hepatectomy or hepatectomy when in a trauma situation, when you don't have all the facilities, when you don't have all the retractions that you need and the backup. So it's quite a difficult task, but people have done it. Yes. Are there any other questions, Prabhat?
No, sir. Those are the questions. So there's a question about what is the maximum time we can apply Pringles maneuver.
I think you answered that. You can re-emphasize that?
So there are different. Yeah, go on, Sujinder.
Yes, Prabhat. No, go on, please. Yeah.
So there are different cycles, as we explained before, about we can apply continuous for 2 minutes and keep a gap of 5 minutes, and there are 5 minutes Pringles maneuver and keep a gap of 1 minute. It all depends on the center, but I don't think there is no one knows that how long we should keep a Pringle maneuver. So there was like studies saying that in a normal liver you can go up to 1 hour continuous Pringle. But applying intermittent Pringle maneuver is important, because once you do intermittent Pringle maneuver, you get ischemic preconditioning. So what they believe is that when you apply Pringle maneuver intermittently, later on, even if you keep the clamp continuously, these hepatocytes are kind of preconditioned for ischemia. But as a practice, we would use 15 minutes Pringles with a gap of 5 minutes inflow.
Anything, Sutinda? Yes.
It depends whether you're doing it for trauma or routine surgery. So routine surgery generally short Pringles, but for trauma, as Prabhat said, there are retrospective studies where they say even 45 minutes of Pringle clamping is safe in trauma, because you have to get the control of the bleeding vessels during that time. So as Prabhat said, I think it's important that if you can release intermittently so that you get that ischemic preconditioning.
Okay, I think we have covered almost all the topics that we wanted to discuss. If anything else, is there any final comments or anything to mention just before we wind up? Okay, so thank you very much for both our speakers, Dr. Sutinda Tilakaratne and Dr. Prabhat Kumar Singha. On behalf of the College of Surgeons, I would like to thank you for conducting this session. And we'll wind up and we'll hand over the proceedings to the main controlling center. Thank you very much.
Thank you.
Thank you, Professor Hans Siriwardana and Dr. Prabhat Kumar Singha and Dr. Sutinda Tilakaratne, the experts who have joined us today to share some knowledge, some practical tips and tricks of the trade on how to manage one of the most dreaded visceral bleeds that general surgeons encounter. And I thank you for all the surgical trainees who took part in the discussions and who sent them questions and discussions on the chat box as well. I'm sure they are more capable of managing, more confident in managing a liver bleed following this discussion. So thank you, everyone. We are just waiting for a little while longer for the completion of the other parallel expert session. And we shall join in a few minutes at 8 o'clock. For the main session commencing with the Bartholomew's Prize. So a few minutes break and we'll join you back soon. Thank you. Thank you. So those who have joined us today following the expert session, may I wish all of you on behalf of the President and the Council of the Sri Lanka Surgical Society a very, very good morning and a warm welcome to day 2 of the Sri Lanka Surgical Congress 2021. We are going to begin the day 2 today with a very exciting and sought after session. It is one of the most renowned research sessions for surgical trainees of the Sri Lanka surgical trainees. May I welcome you all to the Bartholomew's Prize Best Oral Paper Session. To conduct the proceedings, may I kindly invite on the podium and the chairpersons, Dr. Ranga Wickramarachchi and Dr. Pramod Chandrasinghe, to conduct the proceedings.
Okay, thank you. For this session, we have 6 oral presentations, and just to remind, we have allocated 6 minutes for the presentation and 2 to 3 minutes for the question time. So we'll be starting with the first paper, Prediction of Ureteric Length for Prevention of Ureteric Stent Morbidity in Sri Lankan Population. The paper will be presented by T.M. Samarasinghe.
Good morning, everyone. I'm Dr. Tilana Samarasinghe. I'm a Senior Registrar in Urology in the National Hospital of Sri Lanka. I'm going to present our paper on prediction of ureteric length to minimize stent morbidity in the Sri Lankan population. So as we all know, ureteric stenting is the commonest urological intervention. Although it's considered a minor procedure, most of these stents tend to lead to significant morbidity in our patients, and trigonal irritation due to excess intravesical length is proven as an important determinant of stent morbidity. But all those different stent lengths are available. There is a significant deficiency of a predictive formula. Thus, we tend to use empirically longer stents to cover all the population, which may in turn be leading to a preventable morbidity that is ailing our population. So with these in mind, we designed our study, an analytical cross-sectional study done in 2 phases in a single unit in the National Hospital of Sri Lanka. And we included adult patients undergoing ureteric catheter insertion for diagnostic and therapeutic procedures. And we had to exclude patients with known anatomical abnormalities in the upper urinary tract, as well as patients who have been on a stent for the last 4 weeks duration, or who are currently on a stent, because it is known that the ureteric paralysis can cause discrepancies in the ureteric length from the native ureter. Results were analyzed using SPSS software version 21. Going into our study protocol, it was rigid cystoscopy was done and a calibrated ureteric catheter was inserted under image intensify guidance, and the PUJ was confirmed using a retrograde pyelography, and the bladder was filled to 200 ml, and then the vesicular-ureteric junction was identified, and the length from the PUJ to VUJ was measured using the calibrated catheter. These measures were correlated with the gender, anthropometric measures, side of renal unit, as well as imaging findings. Going into descriptive statistics, 41 renal units were analyzed in 39 patients, and the mean age of our cohort was about 49.6 years with a standard deviation of 12.4, and it ranged from 20 to 77 years. Population had a slight male predominance, and as you can see, the age distribution as well as the BMI of our population shows a normal distribution. Going into the ureteric length measures, the mean ureteric length was 22.8 centimeters with a range of 20 to 26 centimeters and a standard deviation of 1.35. But it is interesting to note that only 3 of the 41 ureters that we measured were longer than 25 centimeters. As I mentioned before, we are using empirically 26 centimeter stents on all these patients. And ureteric length measured shows a normal distribution, as you can see very clearly in this histogram. And this visual assessment was confirmed statistically with the scatter plot as well as the PP plot. As you can see, the box and whisker graph also shows the ureteric length to be centered around 23 centimeters. Going into our analysis, multivariation regression using a Spearman's correlation showed that there was a significant contribution to ureteric length when combination of age, height, weight, and BMI were used, and this variance was the contribution for the variance was about 34% with a very significant p-value. Univariate analysis using Pearson's correlation showed that BMI and age had a contribution towards the ureteric length. So in conclusion, Chairperson Sir, I would like to say that the currently used stent length of 26 centimeters is significantly excessive for our cohort of patients, likely our population. Excess stent length may be contributing to preventable morbidity in our patients. However, there is no individual anthropometric measure that can adequately predict the ureteric length, but a nomogram that can be generated using these values may be able to accurately predict the ureteric length, and in doing so, we will be able to individualize the stent usage. All in all, reducing the unnecessary avoidable stent morbidity associated with this excessive stent length. Limitations wise, our sample size was a little small to draw definitive conclusions on the whole population, and we had to exclude patients with anatomical abnormalities such as horseshoe kidneys from our study. So the way forward, we plan to expand our sample size to build a robust nomogram to predict the ureteric length in Sri Lankan population, presumably using a multicentric study. And we plan to test the efficacy of the nomogram in predicting ureteric length and the practicality of using it, especially in the emergency setting, where ureteric stents may be used very frequently. And we want to know whether predetermining the ureteric length and custom stent usage with regard to ureteric length measurements and nomograms, can it prevent our stent morbidity in our population? Is it an effective intervention? So these are what we plan to do with this study. Thank you very much for your kind attention, and thank you very much for the College of Surgeons of Sri Lanka for providing me this opportunity to present our paper in this prestigious forum. Thank you.
Ms. Amarasinghe, now the paper is open for discussion.
Tilna, thank you very much for an excellent presentation. I just have one question. It's regarding this, the assessing of the length of the ureter. How was it done? Was it done by a same person or? So all these procedures are done by a same person?
Thank you very much for the question, sir. Actually, it was done in the same unit, but we used a very standardized procedure to measure the length, sir. There was very little room for subjectivity because we used the standard ureteric catheter, and also the bladder was filled for 200 ml, and we used the visual assessment, the retrograde parallelogram, to identify the PUJ, and the VUJ was also clearly seen. There is a possibility, sir, but we try to minimize it using standardized measures as much as possible, sir.
Tilina, I have one more question. Now you talk about the stent size. Do you think is there a variation in relation to the stent diameter?
So, actually now there is literature that they have tested the stent diameter 5 French versus 6 French and even 4 French versus 6 French. They have not found a significant difference in the efficacy nor the stent symptoms in the previous studies. So we didn't look at the stent diameter per se, whether it correlates, but here our main necessity was to see the correlation with the stent length and the ureters of the patients depending on the anthropometric and other measures.
Thank you, Dr. Samarasinghe. The second presentation of this symposium is phase 1 trial, the use of prostaglandin E1 in patients with non-revascularizable chronic limb-threatening ischemia. And to present the study will be Dr. A.M. Alabadarachi.
On behalf of the University Vascular Unit of NHS Health, allow me to present our free paper on the study on the use of prostaglandin E1 in patients with non-revascularizable critical limb ischemia. Despite having a potentially salvageable limb, around 20% of patients with critical limb ischemia are actually non-revascularizable. This is due to either a poor patient physiology or a disease anatomy that does not allow for a revascularization. Now, as to what happens to this cohort of patients are largely unknown. Even in the global scale, until very recent, there was very little studies and data on how these patients perform. Even the paper in 2021 highlights this fact and suggests that it's possibly that there's very poor long-term survival and limb salvage in this patient group. Now, amputation is always an option in this patient, but it's very clear that these patients who undergo amputation actually have a significantly high morbidity and mortality and a very poor functionality, especially in the Sri Lankan setting. So there is a need to find alternative management options
for patients with non-revascularizable critical limb ischemia. Now, many things, many methods have been studied and trialed and tested, but none of these have actually reached a level of therapeutic use. Of these, however, prostanoids have emerged as a potential solution. Remember, prostanoids as part of the phospholipid metabolism pathway, but what we didn't know then was that prostanoids have an ability to improve the microcirculation and the perfusion in critical limb ischemia based on their actions on the endothelium and the smooth muscle cells and the cellular components. Now, there have been over 32 randomized trials that looked at various types of prostanoids. The last Cochrane review in 2018 suggested that there is some efficacy for treating rest pain and ulcer healing, but no impact on limb salvage or mortality. But they called the need for high quality studies. We looked at the literature review, but we found there's a lot of heterogeneity in these studies. There are different types of prostanoids that have been used. And there's very little consensus on what's the right dose, what's the right dosage, duration of treatment that would give the potential maximum benefit with the minimum side effects. So the absence of any clear consensus and the fact that there's no data to date on the use of prostanoids in the management of non-revascular critical limb ischemia in Sri Lanka, we performed a study with the hypothesis that PGE1 in a particular dosage protocol is able to improve outcomes for patients with non-revascularizable critical limb ischemia. The study itself was designed as a non-randomized, open-label clinical trial over an year's duration. And patients with non-revascularizable critical limb ischemia were included in the study. The study protocol was devised based on a literature review. The dose we used was 100 micrograms for a day, and this was administered over 5 consecutive days. That'd be 1 cycle, and that'd be for a month's duration. Patients received a maximum of 5 cycles of such 5-day prostanoid infusions for a maximum of 5 months duration of treatment. We looked at what happened to the rest pain, what happened to the ulcer size, whether the limb was saved, and the patient survived. Overall, 44 patients were included in the study. These patients were old, were male predominantly, 93% presented with tissue loss rather than pure rest pain. There are a lot of comorbidities as we would expect in this patient cohort. They were followed up for a period of 16 months median duration. The only significant adverse effect noted was an episode of cutaneous allergic reaction, which prompted abandoning of this patient from the trial. When looking at the survival and how these patients performed at 18 months, 72% of these patients cohort survived, and 49% survived with an intact limb, which is quite remarkably good results comparing the outcome of these patients in general. At 18 months, there was a 59% reduction of the median score of rest pain, and 32% had complete resolution of rest pain. At 18 months, 52% of the patients had complete wound healing. When we look at how these patients performed in comparison to those who undergo bypass or angioplasty or primary amputation, what we feel is that these patients do actually have decent results in terms of their overall survival and limb salvage when it comes to 12 months and 18 months duration. In conclusion, ladies and gentlemen, prostaglandin E1 demonstrates a safety with minimal side effects at the dose that we have performed the study with. There's improvement in wound healing and rest pain, and it has improved overall survival and limb survival. There are, however, limitations in terms of selection bias, since only patients who could afford prostaglandin were selected for the study, and the non-randomized open-label nature of the study would lead to an observer bias. However, we feel that prostaglandin does demonstrate potential as a therapeutic option in non-revascularizable critical limb ischemia, and there's proviso for a future double-blinded randomized controlled trial to determine what is the best dose, what's the best dosage method that will give the best treatment outcomes. Thank you.
Right, thank you. That study was presented by Dr. Tushan Gunratne, and the paper is open for discussion now.
Thank you, Dr. Gunratne, for that excellent presentation. I have a question. Now, this prostanoids that you used, the dosage and the protocol that you all used, is it a accepted protocol in other centers, or is it the dosage, the regularity, the duration, is it something that you all came up with? And what about, run me through the ethics and the approvals, etc. Thank you.
Thank you, sir. So in the absence of a clear consensus on this matter, we did a thorough literature review, and we looked at centers that use prostaglandin in different nature. The issues were with the dose, as to what the dose for a day is required for, how many days it should be given, and for how often it should be given, as in cycles. Some people give as intermittent dosage, as continuous dosage. So we used this protocol based on a literature review that suggested benefits in terms of these different aspects. What would be the best therapeutic regime for the dose for a day? What is the best method in terms of a continuous versus an intermittent cycle, and the duration of this treatment course. And India has been one of the pioneer centers that used this prostaglandin infusion for critical limb ischemia, and we used some of their data and some of their concepts in devising this protocol. The idea was to try and come up with the best therapeutic efficacy dose with the least amount of side effects, but with the plan of doing a proper randomized trial with different arms on the strengths of these different dosage regimes as a future protocol.
Did you use any statistical tests to compare the two groups, like the log rank test or anything?
I beg your pardon, compare between the which groups, I beg your pardon?
How did you analyze the survival curves, the Kaplan-Meier curves that were indicated?
So the survival curves are purely based on Kaplan-Meier curves of this present cohort of patients, of the 44 patients. We did not compare the survival of this cohort with those of the angioplasty group or the bypass group, because there was too much of heterogeneity and differences in those patient groups. The comparison table at the end of the presentation was just to depict in figures the different survivals in terms of overall survival and limb salvage. There was no direct comparison between those two, but we used in the multivariate analysis various factors that we think would contribute towards the survival of the patient's limb and the overall survival, such as the presentation with rest pain, the degree of sepsis, the comorbidities, etc.
Yeah, it would have been, if it were useful if you did the log ranks and did a statistical analysis, it would have given more well detail. Thanks.
Thank you, sir. Thanks.
Right. Thank you, Dr. Gunratne.
The next paper will be presented by Dr. C. Aberatna. The paper titled, "Should we continue to perform kidney transplantation during the COVID pandemic?" Over to you.
Good morning. So I'm Dr. Shanaka Aberatna, Senior Registrar in Nephrology from Sri Javardhan Transplant Unit. Today, my topic is, should kidney transplantation during the COVID-19 pandemic continued or deferred? And this is a single center experience from the Sri Javardhan Transplant Unit. Our presentation number is oral presentation number 26. As we know, transplant programs worldwide have been severely impacted by the COVID-19 pandemic. So we know that first case was detected in the November 2019, Wuhan, China. From that 2019 November up to now, the worldwide transplantation program, both live donor and deceased donor program, have been severely impacted. There's uncertainty on the outcome and safety of renal transplant during this COVID-19 pandemic, basically because of the use of potent immunosuppression for the induction and the maintenance. And there is uncertainty about the efficacy and safety of this vaccine in the background of this immunosuppression. The transplant community now eagerly waits data obtained under difficult circumstances during this pandemic. So the purpose of our study is publishing the transplant experience in the single center during the era of COVID-19 infection. This was an observational study carried out in Sri Javardhanpura Transplant Center from February 2020 to July 2021. All renal transplant recipients, including both live donor and deceased donor, included to the study. The total number of participants were 64. The primary objective were the incidence of COVID-19 infection and its impact on graft and patient survival. So out of the total number of 64 participants, there were 55 live donor recipients and 9 deceased donor recipients, and the mean age was 46 years. So you can see the male and female distributions. Majority were males, 72%, and the females were 28%. Vaccination status of these recipients, the overall vaccination status was 59, but it's surprised that the pre-transplant vaccination status was 36%, and majority or 64% got their COVID vaccine after the transplant. So out of this 59, 68% had 2 doses of COVID-19 vaccine at the time of this study carried out, and only 32% had single dose of vaccine at the time of the study. 2 had COVID-19 infection prior to the transplant, but they ended up with successful transplant after the 1 month of recovery. So out of the 64 recipients, 5 had COVID-19 infection. Unfortunately, 2 recipients died and 3 patients survived. So out of 5, 1 managed at home and 4 managed in our Javardhanpura COVID center. So when we consider the vaccination status of these 5 infected recipients, 3 had 2 COVID vaccines, 1 had single vaccine, and 1 has not been vaccinated at all. What is the impact of COVID-19 infection on immunosuppression regime? So induction done with standard IL-2, basiliximab, and methylprednisolone in 60 out of 64 recipients, and only 4 patients received ATG depending on their immunological risk. So basically triple therapy with CNI, basically tacrolimus, MMF, prednisolone used for the maintenance immunosuppression, and we make sure that we continue with the lowest possible dose, and prednisolone tapered to the lowest possible dose, less than 5 milligram over the 8 to 12 weeks period. Those who didn't have vaccination, I mentioned previously 64% prior to the transplant received their first dose of COVID vaccine at 1 month of transplantation. No single episodes of acute rejection detected during the period of follow-up. So we make sure that we kept on monitoring their graft function and especially their panel reactive antibody level, thinking that sometimes vaccination can precipitate the acute rejections and the antibody formation. The conclusion of our study was the clinical presentation of COVID-19 infection was similar to the reported in the general population. The transplant outcome remained acceptable during the pandemic period.
Thank you. Now the paper is open for discussion. We can enter in a few questions.
Thank you. Was the vaccination status a criterion for selecting patients for surgery?
Yes, because the vaccine has been introduced very recently, so the vaccination status is not considered as a criteria for the study, because most of our population, 64 of the study received their vaccination after the transplant.
What is the take-home message that you'd like to give in this?
So what we learned here, so those who had COVID infection prior to the transplant, the 1 month defer period is enough from the recovery. The second take-home message is, so vaccination status, if it is possible, it's fine. But even after the 1 month after the transplant, we offered their first dose of vaccine, and we make sure that we monitored their SARS-CoV-2 specific antibody response to the vaccine following the transplant, and depend on that, we offered the second dose and booster dose with mRNA vaccine.
Thank you very much.
You had 5 patients with COVID infection during this course of the study. Is that how did you feel statistically? What was the sort of the power and the conclusions that you derived from this? How confident do you feel with the numbers that you have taken on board in this study?
It's actually 5 patients after the transplant and 2 patients prior to the transplant, because we make sure that during the transplant period we introduce this bubble technique to the transplant, because we admitted these patients 7 days prior to the hospital, and after even transplant, we offered both the recipient and donor this strict isolation technique. But that's why the post-transplant, the number is quite the 5 out of these 64. So, hello.
Yeah, have you got any more questions from the floor? Right, in the absence of any further questions, we will close the paper. Thank you, Dr. Abeyratne. Next will be, do live donor renal transplants yield better outcome? Comparison of outcome between living donor and deceased donor renal transplantation. To present the paper, Dr. Y. Manikage. Over to you, Dr. Manikage.
Good morning. I'm Dr. Yasuni Manikage from Urology and Transplant Unit of Sri Jayawardhanapura General Hospital. Our research was on, do living donor renal transplant yield better outcome? Comparison of outcome between living donor and deceased donor renal transplant. Chronic kidney disease is a major health burden in Sri Lanka, mainly due to rising CKD-U and diabetes, with nearly 150,000 people affected by it. Patients with end-stage renal disease must receive renal replacement to survive, dialysis or kidney transplant. The waiting list for organ transplantation continue to grow, but the supply of disease and living donor organs are stable as according to the international literature. However, these figures are not available for Sri Lanka. As you can clearly see here, in South Asia and Southeast Asia, majority of kidneys for transplant come from living donors, unlike in the West, where disease donation is well established. In the Western world, disease donors outnumber living donors. As I said before, organ donors can be of 2 types, living or deceased. Disease donation helps to bridge the gap and minimize the waiting list for kidney transplant. Disease donors can be of 2 types, donation after brainstem death or cardiac death, but DCD is still not legalized in Sri Lanka. This graph shows a comparison of kidney transplantation patient survival in Australia and in the USA. At 1 year, overall survival of both the countries are at 98%. According to international literature, patient survival is marginally superior in live donation, but transplantation, even from a deceased donor, is far better because 5% of patients die every year despite dialysis, even at the best centers. Disease donor transplantation was established at Sri Jayawardhanapura General Hospital in 2016 and is slowly gaining momentum. There is no comparative study done on live and deceased donors outcome in Sri Lankan literature. Hence the reason for our study. The primary objective of our study was to compare the survival rates between living donors and deceased donor transplant patients. The secondary objectives were perioperative outcome, delayed graft function, and complications between the two groups. Our study was a retrospective cohort study done at Sri Jayawardena General Hospital Transplant Center from February 2016 to December 2020 with a study population of 167, 123 living donors and 39 deceased donors. Patients who underwent first transplant and who were given standard immune induction agent and triple therapy were chosen for the study. Patients with high immunological risk who needed plasma exchange or ATG or patients who underwent second transplant were excluded. So 5 patients were excluded from the study. We compared patient and graft survival, perioperative outcomes according to Clavien-Dindu classification, delayed graft function where patients needed dialysis till the kidney started functioning, and graft rejection, which was clinically detected by rising creatinine and supported by biopsy if needed. And the study was analyzed using statistical tools. The study included 123 live donors and 39 deceased donor transplant patients. Age, sex, blood group were comparable in both the groups. Diabetes was the predominant comorbidity in both groups, and more or less the groups were comparable. The cause for end-stage renal disease was also predominantly diabetes, with other causes having varied distribution. The main difference between live donor and deceased donor was the cold ischemic time. It is understandably high in the deceased donor group as donor organ harvesting takes a longer time and it was statistically significant. Delayed graft function was noted only in 2 patients. They required dialysis until their kidneys started functioning. Clinical rejection was seen in 14 live donors and 7 deceased donor transplant patients and was significant. Overall patient survival at 1 year was 95.2% in live donors and 94.9% in deceased donors, and the cause of death was not related to the graft function, as a majority of deaths were due to myocardial infarction, septic shock or pneumonia. When you compare international literature with Sri Lankan data, the 1-year patient survival in Australia and USA is at 98%, whereas Sri Lanka has a 95% 1-year patient survival rate despite our resource poor setup. When looking at complications, major complications were correlated with some delayed graft function and clinical graft rejection, but it did not alter the overall patient survival. Even the patients with graft rejection were salvaged with advanced medical management. Our results showed that short-term outcome of live donor and deceased donor transplants have no significant difference. In conclusion, deceased donor transplants are safe and effective, and long-term follow-up is needed to meet the international survival rates. Thank you.
Thank you, Dr. Manikage. The paper is open for discussion now.
Congratulations, Dr. Manikage. I have a question now, the live versus the diseased donor transplants. Did you try to see whether the 2 cohorts matched in any way, or was there any major differences in the 2 groups?
Hello?
Hello, Dr. Manikage. There's a question from one of the judges. Did you get the question?
If I can repeat the question, Dr. Manikage, can you hear me? Dr. Manikage? Can you hear us, Dr. Manikage?
Sorry, sir. Good morning. I couldn't hear earlier. There was a connection drop.
I'll repeat
Sorry.
the question. Yes.
Okay.
So,
Sorry about it.
You have looked at two groups. The numbers are different, but did you overall look at the live versus the diseased donors? Was there any big difference in their ages, their BMIs, or their comorbidities, or were they a comparable group? Thanks.
Yes, sir. So we had 123 live donors and 39 disease donors, recipients actually. So we did compare their age, their blood group, their sex, comorbidities as well. Majority of them had diabetes and hypertension as comorbidity. And the reason for end-stage renal disease was diabetes in both the groups.
Excuse me, Dr. Manikage, the question was regarding the donors, not the recipients. Did you compare the two donor populations?
No, sir, we did not. We did not.
Right.
Yeah.
Did the deceased donors came from the same center you had transplantations?
Sir, so some of the disease donors did come from our hospital as well, and then some came from outside hospital. That is the reason why there's a big variation in the cold ischemic time, because when the patients did come from Jayawardhanapura itself, the cold ischemic time was practically comparable to the live donation, because when we open the patient in one theater, the retrieval is done in one theater and the donor recipient is done in the other theater at the same time. But when we get the kidneys from a hospital from far away, that's why there's a long cold ischemic time, sir. That was the main difference between the two groups, the cold ischemic time.
Thank you.
Thank you, Dr. Manikage. We have reached the allotted time.
We'll move on to the next paper. The paper titled Anatomy of Epigastric Vessels in the Sri Lankan Population, and to be presented by Dr. K.G. M.W. Bandara. Over to you, Dr. Bandara.
Good morning, everybody. I'm Mahesh Bandara from University Surgical Unit National Hospital. First of all, I would like to thank College of Surgeons for giving us the opportunity to present our research finding. Research topic is Anatomy of Epigastric Vessels in Sri Lankan Population. As you all know, minimal access surgery, especially the laparoscopic access, has revolutionized the field of abdominal surgery, and it's widely available even in base hospitals of Sri Lanka. Damage to anterior abdominal vessels are a known complication of port insertion. Epigastric vessel injury incidence varies from 0.2 to 2% of laparoscopic procedures. There were very few studies performed to map the location of epigastric vessels, but all have done among the Caucasians. Asian population body habitus is significantly different from that of Caucasians. So, mapping the anatomy of epigastric vessels in our population will help to avoid injuries during the laparoscopic port placement. General objective was to identify the epigastric vessel location in relation to fixed anatomical landmarks. Specifically, we wanted to identify the safe sites for laparoscopic port placement. It's a descriptive study conducted at the Department of Radiology National Hospital, including the patients who underwent abdominal CTs from January to December 2020. We excluded patients who were less than 18 years and more than 75 years of age, and patients with previous abdominal surgeries, large ventral hernias, large intra-abdominal tumors which may alter the normal anatomy of the abdominal wall. Apart from the basic demographic data, we collected the circumferences at umbilicus level and the distance from midline to each epigastric vessels at the following levels: 3 cm below syphis sternum, 2 cm above umbilicus, 2 cm below umbilicus, at the level of anterior superior iliac spine and 3 centimeter above pubic symphysis. All the levels are corresponding to the commonly inserted port sites. We analyzed the data using SPSS version 25 and values were obtained expressed as the mean and standard deviation. In our cohort, the males, 52 patients are male and mean age was 49.28 years and the mean abdominal circumference was 87.15 centimeters. In this table, you can see the mean distance from the midline at each level for the left and right deep epigastric arteries. This is well explained by this diagram where you can see with the arrow mark, the star marking to the anatomy of the epigastric vessel at each fixed location. And we divided this distance by the circumference at the umbilicus level to find out get a standardized distance factor. And these are the standardized distance factor for each level. So we can conclude that epigastric vessels injury can be prevented if the epigastric ports are inserted 4 cm lateral to the midline, lateral ports are inserted more than 8 cm from the midline, and suprapubic port inserted within 3 cm from the midline. This also can be explained well by this diagram, where the arrow markings are for the mean distance and the red arrows are for the range, and these dark markings, the dark areas are safer sites for laparoscopic port placement. So in the epigastric port, it should be more than 4 cm lateral and the lateral port should be more than 8 cm from midline, and the suprapubic port should be within 3 cm from the midline. Thank you.
Yeah, thank you, Dr. Bandara. The paper is open for discussion now.
Dr. Bandara, congratulations. I have a question. The recommendations of the distances, is there any correlation with the stature of the patient? I think you had measured the abdominal circumference. Did you find any correlations with that, body mass index, etc.? Thank you.
Dr. Bandara?
Yeah. Sorry. Thank you very much for the question. And actually, we standardized the patient by measuring the circumference at the umbilicus level. So when we get a patient with a high risk of bleeding or for a risk of laparoscopic bleed, the port entry bleeding, we can measure the patient's abdominal circumference and multiply it by this at that level, the standardized factor, to get the exact level of that particular patient's distance. So by that we can avoid the injury. So that's how we standardized. We didn't standardize to the height or the weight, but we standardized the patient to the abdominal circumference, which we can measure easily.
Dr. Bandara, how do you see this data being applied in a practical sense? Are you recommending the surgeons to measure the distance from the midline and insert the ports? Because once you get in with your camera port initially, then you have a direct vision of the posterior the posterior rectus sheath. So, and then the principle is strangulation. So, are you advising surgeons to be rigid about these distances? Because we know that triangulation is very important. It varies based on where you operate inside the abdomen. What are your thoughts?
Yeah, I understand that it's the main concern is safe surgery. So if you get a port side bleed, that can take the surgeon's concentration away from that at the critical time. So it will take unnecessary time for arrest the bleeding, or it can increase the blood loss. So in a significant patient that whom we are considered more about this port side bleeding, we can take this into consideration while achieving the triangulation as well. So it's not to go by rigid the measurements, but to have a rough idea about the anatomy of the vessels, and to avoid, if possible, this not to compromise the safety and efficacy of surgery by these distances. This to prevent when possible.
Dr. Bandara, when you distend the abdomen, can these dimensions be altered? Have you considered the distension of the abdomen, and with that alterations that occur in the measurements?
Yeah, that's a good question, sir. We didn't measure on patients. We roughly calculated these distances on the CTs to these things. Yeah, I understand that can be little vary, but it's our idea was to have the anatomy in living patients.
Yeah,
so
because yeah, sure, continue.
Yeah, and it says that now when you put the camera port and you transsimulate, what you can see is the superficial epigastric vessel, but the deep epigastric is deep to the posterior rectus sheath, which will not be able to identify with the transillumination. So that's why we went with these live patients, the CTs of these patients.
Thank you, Dr. Bandara. We are running out of time, so we shall move on to the next paper. Thank you, Dr. Bandara. The final paper on the session is Significance of Amylase Level Measured in Drain Fluid on Postoperative Day 1 after Pancreatic Resection in Predicting Postoperative Pancreatic Fistula, a multi-center prospective observational study. To present it, I invite Dr. G.P.U.P. De Silva. Over to you, Dr. De Silva.
This is a multi-center prospective observational study on the significance of amylase level measured in drain fluid on postoperative day 1 after pancreatic resection. I am Dr. Upul De Silva from Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. Pancreatic resections in terms of pancreatic duodenectomy, segmental pancreatectomy, and distal pancreatectomy are performed for a variety of benign and malignant pathologies. Postoperative pancreatic fistula is a critical complication following pancreatic resection, with the incidence ranging from 3 to 45%. It leads to potential lethal consequences including deep surgical site infection, hemorrhage, and organ failure. In addition, it is responsible for longer hospital stay and greater healthcare cost. Traditionally, drain amylase is measured on postoperative day 3 to identify pancreatic fistula. However, early prediction of the development of pancreatic fistula on day 1 itself is important on two aspects. Early recognition of high-risk patients would enable to retain surgical drains, prompt use of antibiotics, extended use of octreotide and parenteral nutrition prior to clinical deterioration. Similarly, recognition of low-risk patients allow removal of surgical drains and early establishment of oral feeding, which would facilitate better healing and faster recovery. We conducted this study with the objective of describing the significance of assessing day 1 drain amylase level to predict the development of pancreatic fistula following pancreatic duodenectomy, distal and segmental pancreatectomies. Moving on to the methodology, this was a prospective observational study conducted at 3 tertiary hepatobiliary referral centers in Sri Lanka from January to July 2021. Patients who underwent pancreatic resections including pancreatic duodenectomy, distal pancreatectomy, and segmental pancreatectomy were enrolled in this study. Exclusion criteria included patients undergoing emergency pancreatic resection, development of pancreatic fistula following trauma or non-pancreatic surgeries, patients undergoing drainage procedures for chronic pancreatitis, as well as enucleation of pancreatic tumors also excluded from this study. Surgical techniques for all patients were according to the standard practice. All patients were administered octreotide prophylaxis of 100 microgram 3 times a day postoperatively. Drain fluid amylase levels were recorded on postoperative day 1 and day 3. Development of pancreatic fistula according to the international study group on pancreatic fistula criteria was recorded. Out of 38 patients, 50% were females and mean age was 56.5 years. 11 pancreatic and 27 distal pancreatectomies were included. 10 patients developed pancreatic fistula. Out of them, 9 patients developed only biochemical or grade A fistula. However, 1 patient developed grade B fistula which required a persistent drainage for more than 3 weeks. We observed the soft consistency of pancreas was significantly associated with the development of pancreatic fistula. We observed a significant difference of mean day 1 drain amylase level between those who developed a pancreatic fistula and those who did not. We analyzed receiver operator characteristic curve of day 1 amylase level. The value was 0.62. A cutoff value of 252.8 units per liter, which provided 80% sensitivity and 43.9% specificity to predict the development of pancreatic fistula is noted. Day 1 drain amylase has been investigated as an early predictor of pancreatic fistula in the literature. However, we observed a lack of uniformity of these studies. Most of the studies are confined to a particular type of pancreatic surgery and provide variable level of predictive cutoff values. As an example, Vaz et al. Has shown a cutoff value of more than 600 to predict pancreatic fistula. However, Sutcliffe conducted a study which showed a lower cutoff value of 350 to exclude the development of pancreatic fistula. Contrary to our results, Selga and group demonstrated a low sensitivity and positive predictive value of day 1 amylase level as a predictor of the development of pancreatic fistula. So in conclusion, day 1 drain amylase level predicts the development of postoperative pancreatic fistula with an acceptable sensitivity according to the preliminary results of this ongoing study. This brings us to the end of this presentation. Thank you for listening.
Thank you, Dr. De Silva. And the paper is open for discussion now.
Dr. De Silva, what do you mean by pancreatic softness?
Thank you, sir, for the question. Actually, it's a intraoperative assessment of the pancreas. So, it's a subjective assessment of the pancreas where we see the pancreatic consistency by the tactile sensation. So, we generally go by the hardness or softness of the pancreas. That is one of the predicting factors for the development of the pancreatic fistula. So, actually, there can be intra-observer variation of that the factor. However, that is one of the important predicting factor, so we included in this study.
Yeah, I mean, that's what we need to appreciate that it was done in 3 centers and there could be a wide disparity in the appreciation of softness among the operators.
Yes, sir, that could be.
Thank you.
Thank you, sir.
The findings of your study, you quoted some of the earlier studies which found a difference in the pancreatoduodenectomy versus distal pancreatectomy. In your study, did you do a subgroup analysis as well?
No, sir. Actually, I quoted a few studies that they are confined to a particular type of surgery, not to compare between the surgeries. So here what we did is, whatever the pancreatic resection we do, that is our target is to see the development of pancreatic fistula, not to compare the type of surgery. So we included all types of pancreatic resections, routine resections, to see the risk of the development of pancreatic fistula.
So amylase in a univariate analysis.
I'm sorry, sir.
You didn't take into account the other variables and attributes that would contribute, or just amylase as a single analytical factor?
our main target is to see the amylase level to predict the pancreatic fistula, but for the other multivariate analysis, we include the consistency of the pancreas as well as the diameter of the duct. So here our main aim is to see the amylase level, which is that is with that we diagnose the pancreatic fistula on day 3. So we tried to see the correlation between the drain fluid amylase on day 1 to predict it early before we diagnose it actually on a patient. So we can anticipate the high risk patient, and we can we can be prepared for the coming consequences. So we can minimize with extended use of octreotide and even maybe parenteral nutrition, and we can delay the we can even delay the oral commencing on the oral on these patients.
Now one more question. Now these 3 centers, the surgeons, have they followed the same protocol, or it's like, I mean, I'm thinking of the surgery, the technique of surgery, or is it same across all these 3 units?
So the pancreatic resection are standard, they are usually standard. So here we are not assessing the type, the way we did the surgery, we are assessing the postoperative complication as a pancreatic fistula. So the important thing here is we standardize the octreotide use and the placement of drainage.
I mean, the time and the the technique also could have contributed, isn't it, to the fistula formation? That's what I'm thinking of.
For routine surgeries, sir, yes, I understand, sir, but we use the standard technique. We didn't go through a common session to have a standard practice, sir. That I will include in my, because it's an ongoing study, so I will include in the previous.
Thank you.
Thank you, sir.
Thank you, Dr. De Silva. And that concludes this session. Thank you very much for all the presenters and the judges.
Thank you, Dr. Pramod Chandrasingh and Dr. Ranga Vikramarajchi. Ladies and gentlemen, we have now reached an exciting session on the day 2 of the Sri Lanka Surgical Congress 2021. To begin the first plenary session, may I invite Professor Ishan D'Souza and Dr. Mahindra Malvatantri onto the stage to introduce the guest speaker for the plenary session. Thank you.
Good morning, everybody. This is plenary 8. Our guest speaker is Ms. Claire Backnott. Without further ado, let's start the lecture. She's a consultant general and colorectal surgeon, Royal College of Surgeons of Edinburgh, United Kingdom.
Hello, good morning. I'm very glad to be here today to speak to you about the impact of COVID-19 on colorectal cancer diagnosis and treatment in the UK. I do wish I was there in person in Sri Lanka, but I do hope that you are all well. Now, obviously, across the world, every health economy has been challenged with the COVID-19 crisis. But unfortunately, as you can see from this picture here, in the UK, we're still in a very high prevalence area for COVID. We're into the third wave, where we're still having almost 40,000 new cases per day. And sadly, we've had over 144,000 deaths. Undoubtedly, the vaccination programme has reduced the severe disease and the intensive care unit use that was seen previously, but it's still very sad figures. And of course, with figures like this, it has had a massive impact on our ability to provide surgical care for other conditions. And that's for a number of reasons. The first is we have had to completely change the physical environments of our hospital to allow social distancing to reduce inter-hospital transfer of COVID. And we've also had to change how we work in terms of we're working much more from home, remotely, doing a lot more virtual clinics, so we don't have so many patients coming into the hospitals. In terms of accessing investigations and diagnostics, initially and during the first wave, we had to stop all endoscopy and colonoscopy procedures And of course, this has caused a huge backlog in diagnosis. And COVID has had an impact in all of us, whether you're a trainee or a consultant, in terms of the fact that you've missed training opportunities, or you've maybe had to take time off because your other conditions meant that you couldn't physically work on the front line. And so I think it's been a very difficult time. What I'd like to talk about today, just for the next 15 minutes, is to show you some of the evidence that we now have that the impact that the first wave had on colorectal cancer diagnosis and treatment in the UK. But then in the second half of the talk, I'd like to spend a little bit more time on the more positive aspects that have come out of this, because certainly COVID has really challenged us to redesign how we manage and triage our patients who have got suspected cancer. And I think it's led to some definite improvements. And I'm going to describe our initial experiences with using FIT, the stool sample test, as a triage tool, and also the early introduction and our experience with the colon capsule endoscopy. So taking you right back to the very beginning of the first wave, there's a diagram here, a graph that shows a red line showing elective operations and a blue line showing, the red line showing emergency operations and the blue line showing elective operations. And you can see that in the first and the second wave, there was a massive reduction in elective surgery. It's estimated that over 1 million elective operations have been cancelled in the UK. But it wasn't just operations. All routine referrals were sent back to the general practitioners. Across all cancer specialities, urgent cancer referrals were down by over 90%. And we were extremely limited in terms of the diagnostic tests that we could perform as an outpatient, particularly in terms of endoscopy and colonoscopy, because of the initial concerns around virus exposure to health staff. And so that really, for almost 6 months, there was no capacity at all for colonoscopy. And there's now some evidence to show exactly what an impact this did have on our patients. This is a paper published earlier this year in the Lancet, which has been, all the evidence has been brought together by the team that run the National Bowel Cancer Audit in the UK. And they've used all the 4 public national databases to come up with this. And what they've done is they've compared our pre-pandemic performance with the performance that happened at the peak of the first wave. And they showed, quite dramatic findings, that there was a 63% reduction in urgent referrals for colorectal cancer. There was a 92% reduction in the number of colonoscopies that were performed. There was 31% less cancer operations performed than would be usually expected during that time. And sadly, they reckon at least 3,500 patients have had delayed diagnosis in terms of colorectal cancer over this time period. In terms of what happened to actual surgery, they've shown that there's been a significantly higher rate of stoma formation during the first wave. There was lower laparoscopic surgical rates of surgery. And this is because, again, there was some concerns early on about aerosol generation during laparoscopic procedures. And there was a massive increase in the use of short course preoperative radiotherapy. And the reason this was done is because basically we just couldn't get our patients into hospitals in a safe area to do their rectal cancer operations. So we used that as a holding therapy and took much more of a watch and wait approach in these patients. And this data also echoes what we found from some other papers, such as this one from the COVID SAARC Collaborative. This is a observational cohort study that was published in colorectal disease last year, and that followed prospectively over 2,000 patients in 40 different countries who looked at what happened in their hospitals during the COVID period. And what they found was in the 2,000 patients that they did go ahead and do anastomosis in about 84% of patients. But if you look at the red circles on the diagram, as you can see here, if you got a COVID-19 infection with an anastomosis and you suffered an anastomotic leak, your mortality rate was 38%. If, however, you'd had a stoma performed and didn't have an anastomosis, but then you got a COVID infection, your mortality rate was much less at 14%. So I think this did really confirm the early data that suggests very poor outcome with an anastomotic leak and COVID infection. But what was interesting from this data is that they compared it with some historical European data, and they found that in general, there was fewer anastomotic leaks than normal. There was less admission of these patients to critical care units, obviously because it wasn't available. They also found much higher stoma rate formation. And when the surgeons were asked about whether they changed their clinical practice in any way, about 4% said that in certain patients they did, and that was often to avoid anastomosis in the very high-risk patient, or else to try and prevent their admission to intensive care, or try and get them out of hospital quicker so they didn't pick up COVID. So that was very interesting data. So in summary, there's no doubt that during the first wave, colorectal cancer treatment in the UK and across Europe was significantly impacted in terms of delayed diagnosis, reduced surgical intervention, a change in our surgical interventions with lots more stomas, and an increased use of short course radiotherapy. But I'm glad to say that after this period, we really realised that we couldn't let this happen again. We couldn't just let cancer services go to the wall. We had to try and protect them as much as we could. So we really got our act together for before the second wave came in. And by that stage, most hospitals had formed green COVID light areas where we had excluded our elective patients from the acute patients that were coming through hospitals. We'd sorted out what to do in terms of preoperative pathways, in terms of swabbing and isolation. We ensured that all our patients were vaccinated. And what we've found really over the last year or so now is that it's starting to feel much more like normal in terms of our MDT decisions. Our laparoscopic colorectal surgery rates are back to normal. The stoma rates are what they were in pre-pandemic levels, and our decision-making in terms of other adjuvant oncological therapies is very much where it was before. The only thing that's stifling this slightly is that we do face a significant workforce crisis in the NHS at the moment, because a lot of the theatre staff who were redeployed to intensive cares during the first COVID wave have left. And so that's the only thing that's keeping us back from moving forward. So I'm now going to change tack a little bit and talk to you a little bit about the positive things and the change that COVID has brought with it. Because when we came out of the first wave, we had this huge backlog of referrals and still, and we had no colonoscopy for 6 months. So we had to think of a way of how we're going to triage our patients to make sure that we use the resource in the best way, so that the patients who are most likely to have colorectal cancer will be diagnosed first. And unfortunately, we know, I'm sure everyone in the room knows, that actually using symptoms as a means to try and prioritise patients is no good, because even with patients with very significant change in bowel habit or rectal bleeding, only about 7 or 8% of those will actually have colorectal cancer. So this made us switch to using a FIT test. And this is a stool test, which is an immunoassay for human hemoglobin, and it can pick up very small amounts of human blood in the stools, up to 2 micrograms per gram, and the maximums are over 400. And this is taken over from the old-fashioned fecal occult blood test. And there's lots of evidence now in the literature. Here are 2 large studies published this year, one from gut and one from colorectal disease, that showed in one over almost 10,000 patients that patients who have less than 10 micrograms in their stool, they have a very strong negative predictive value for colorectal cancer of 99.6%, and that was borne out in the other study. So this made us think that possibly we could be using FIT to help us triage or prioritise our patients. And I'm just presenting here some data from Scotland. This was a retrospective study that looked at almost 5,000 patients who had both a FIT and a colonoscopy. And if you look at the table to your left-hand side, you'll see that at low levels of FIT, which is less than 10, which we would term a negative FIT test, only 14 patients actually were found to have cancer. And essentially what that meant was that you'd have to scope 155 patients, do a colonoscopy in 155 patients to diagnose one cancer. But if you look at the other end of the table where the FIT level was over 400, you only have to scope 5 of those patients to diagnose 1 cancer. So it's very significant. And so what has been suggested, although it's not yet nationally agreed, is that patients who have colorectal symptoms should have a FIT test performed by their general practice and a full blood count before they're referred in. If their FIT test is negative, less than 10, then they don't require any urgent investigation unless they have an anemia or persistent symptoms. If it's between 10 and 150, then we might consider something like a colon capsule endoscopy or colonoscopy. But if it's more than 150, then you would consider urgent colonoscopy. Now, I'm going to mention colon capsule endoscopy because I think COVID has made us adopt this very rapidly, and it's a very interesting technique. If you haven't come across it, essentially it's a mini capsule that has 2 cameras that you swallow after bowel preparation, and it passes through the guts in about 10 to 12 hours and sends the pictures back through to a wireless recorder. This is the recorder here that the patient just wears in a belt. The downside of this is that you have to have very significant bowel preparation. It's usually twice as much as you have for a standard colonoscopy. And if the patient hasn't passed the capsule within 24 hours, then you should administer suppositories. The images are uploaded to the cloud, and it takes about an hour to read a capsule endoscopy, the pictures. But there are a number of trained nurses now that have been trained to do this, and there's now a number of trained gastroenterologists and surgeons also who will do a second look. Now, it's an excellent test, but obviously there are some downsides from it. The bowel preparation isn't very nice for the patients. The battery life of the capsule is actually only about 12 hours, and some people might not have got the capsule might have travelled all the way to the anus before it runs out. It's a very rare possibility of capsule retention, and that may need surgical removal if the patient's obstructed. And obviously, if you find something, the patient still has to come back for an endoscopy. Now, there's now quite a lot of evidence and literature to support its use. This is one of the big studies presented here, which looked at comparing capsule endoscopy with CT colonography. And that's found that both modalities are very good at finding cancers. But in fact, colon capsule endoscopy might be superior in picking up more significant lesions at over 6 millimeters. However, there is a failure rate of about 19 to 20% with capsule endoscopy because of poor bowel preparation. We've got some further data about this from Scotland. I'm very grateful to Professor Watson from the Highlands who sent this to me. But this has been introduced a couple of years ago, and they've got data on about just over 1,000 patients now. And what they've found is that these patients, most of whom have come out through either a routine or urgent referral pathway, only about 35% of them have had to go on to have a full colonoscopy. So it seems to be reducing the need for colonoscopy by about 60 to 70%. So that may be very helpful, particularly with the backlogs that we have at the moment. So what's the future of colon capsule endoscopy? It's difficult to know. Certainly it's been embraced rapidly throughout the UK. I work in Northern England, and in my unit, we now have one of the surgeons trained to read this, and we've introduced it to our FIT negative patients. But again, it may be useful, particularly if we have another outbreak in the pandemic, because this is a completely community-based test, and it can keep the patients away from the hospital. It is costly, however, and whether or not the costs are justified, only time will tell. So just to conclude, there's no doubt that COVID-19 has had a significant impact on the diagnosis of treatment of colorectal cancer, particularly during the first wave. Although I think now that we have introduced strategies to mitigate most of these risks. What it has done, however, is there has been some positive things with COVID in the terms that it's made us think about how to streamline our urgent referral process by using FIT as a prioritisation test. And it's also made us rapidly assess some of the new technologies which might reduce reliance on invasive colonoscopy in time to come. I'd just like to finish by thanking Professor Watson and Dr. Campbell McLeod from Highland for the ScotCap data. Thank you.
Thank you, Ms. Claire Nord, for an excellent talk. I don't see any questions on my screen. Are there any questions from the audience? Can I just ask you, supposing this pandemic were to go away and in a couple of years we get a new pandemic, what would you do differently? Right. Okay. It appears that she's not available online. And let me just thank her once again for her talk. Thank you.
Thank you, Chairpersons. Ladies and gentlemen, it's time for the next plenary session, and one that has been very sought after and very interesting, especially with the role of non-technical surgical skills that are expected in the modern day surgical training. May I invite on stage Dr. Jayendra Fernando and Dr. Chande Masurirachi to introduce a visiting plenary speaker.
Good morning. I think we are a minute or two ahead of the program. So our speaker for Plenary 9 is Professor Lim Keen Gee, who is the president of the College of Surgeons, Academy of Medicine of Malaysia. And he's a very important person and a visitor to our country as he links our college with the Malaysian college. So may I invite Professor Lim to make his presentation, and the title is Non-Technical Surgical Skills in the Life of a Great Surgeon. Professor Lim.
Let me begin by bringing you greetings from the College of Surgeons of the Academy of Medicine of Malaysia and saying thank you to your President and the College of Surgeons of Sri Lanka for this honor of addressing all of you at your historic 50th Golden Jubilee Congress. Let me begin by saying that the ties between our two colleges is not new, and as you can see, I've already received a gift from you in the form of this tie that I'm wearing. As surgeons, we have an interest in and concern about professionalism, and I thought I should speak to you on that aspect today. You may or may not have heard about the non-technical skills for surgeon, or NOTS course for short. It was developed beginning in 2003 by Simon Patterson Brown and Steve Yu from Scotland to address adverse events in surgery. I also happen to have an interest in the history of medicine, especially in Malaysia, and I have learned about an amazing doctor in Malaysia who came from Sri Lanka. So I have the opportunity to link this to the life of the surgeon in my talk today, and it is the life of Arumugam Viswalingam in the light of non-technical surgical skills. The need for the NOTS course, let me introduce it, arose when studies showed errors in the operating theatre were usually not the result of surgeons performing technical errors such as not knowing anatomy or even intricate maneuvers in the operation, but usually of behavior. The elements of behavior were studied and put into a training course that has been included in training in many parts of the world, as you can see from this map. And in Malaysia, we have benefited from this over the last 5 years. The elements of behavior have been put into 4 domains, namely situation awareness, decision making, communication, and leadership. We often find a chain of events in these areas when errors occur and result in poor patient outcomes. So this course trains us to be mindful of these things. NOTS is usually a one-day program, but I am just going to illustrate these principles to you in the life of a great doctor. Let me begin with a teaser. This picture shows a microorganism some of you may already be trying to guess or know about. It is the spirochete. It causes at least 2 diseases, syphilis and yaws. I mention this because yaws was very prevalent in Malaysia before the advent of antibiotics. It was common as worms were in a Malay village. From the high mound to the low, many had troublesome ugly sores as you see here. It wasn't fatal most of the time, but chronic. We don't see yaws anymore. And the reason is because of this man. Arumugam Viswalingam was born into a family that had resided for generations in the village of Urelu in northern Sri Lanka. He was the oldest of 7 children. At the age of 5, he was admitted to the village Christian mission school and completed his schooling at the Chandarodia English Institute in Jaffna, passing the Cambridge School Certificate in 1906. With a spirit of adventure, he got his parents' consent to visit Singapore in 1907. There he decided to take up the study of medicine and was successful in the competitive examination to select applicants in 1909 and obtain a scholarship. He was among the 4th batch of students to graduate from the 6-year course of study at the King Edward VII Medical School in 1913 and was posted to Perak for 4 months as assistant surgeon to the Tapa District Hospital. Dr. Wiswalingam went on furlough to Sri Lanka in 1918, and on his return he was posted to Ipoh briefly, then to Kuala Kangsar. There he recorded a record number of rare surgical cases. Since I'm speaking to surgeons, I think you would be interested to know the operations that he did in those days. He performed gastrojejunostomy, splenectomy, nephrectomy, operations for liver abscess, inguinal hernias, amputations, wiring of comminuted fractures. However, medical officers were actually also technically in charge of sanitation, but were usually mostly concerned with the curative aspect and could usually ill afford to give much time and energy to sanitation work, even if they had the inkling. However, it was in this area that he made greatest impact. In 1919, Dr. Wiswalingam visited Upper Perak and observed several cases of yaws. His opportunity came when he met the district officer, Raja Abdul Aziz, who was himself affected. Realizing the causative organism of yaws was similar to syphilis, he ventured to use Salvarsan to treat it. He offered to treat the Raja with the injection, but the Raja was reluctant. Datuk Yahya, the penghulu of Lenggong, who was accompanying the Raja, remembered a female relative staying with him who had extensive lesions of yaws. She was anxious to be cured and availed herself of the injection. There was no ethics committee in those days, so no consideration of off-label use of a drug, no clinical trials, but I want to discuss what I said about knots. Wiswalingam could have gone home from that visit without doing anything, but he was conscious of the opportunity the situation presented him. He made a connection between the science he knew and the situation before him. Neo-Salvarsan had been newly launched by Paul Ehrlich after meticulous investigation for a chemical that could treat syphilis. And syphilis was caused by a spirochete. Yaws was also caused by a spirochete, and before him was a patient with yaws, and nobody had ever treated yaws before. He made the connection. He thought outside the box. He took the situation in consideration, and he did something. He was aware of the situation. Back to Wiswalingam. On his subsequent visit a month later, Wiswalingam said he found almost the whole village crowding at the penghulu's house. It appeared, he said, that the first day or two after the injection, the lesions of his patient dried up. Within the next 3 to 4 days, the scabs dropped off. Almost the whole crowd came because they had yaws and desired to be treated. I guess what to do seemed obvious. Treat the people there. Get more supplies and come back. We make on-the-spot decisions like that all the time. Our training sense and our experience almost leads us to automatic decisions. But there is a second level of decision making we need to be conscious about. In about 3 months, he treated over 5,000 patients, but Dr. Wisperlingham then undertook an investigation into all aspects of yaws, ascertaining the incidence by means of a census and launching a systematic campaign to eradicate the disease. In the notes course, we discuss these two ways of decision making in order that we take note that when and how to apply them. The first is a rapid response based on our experience and training, and it's obvious and quick. The second is like a chess player thinking of the options before him. It is not automatic and might not happen if we do not pause to ponder. As surgeons, we need to remember to do things better in the interest of our patients. But this only happens when we take time to pause. Sometimes at the operation, we need to think whether there are other options, discuss with our colleagues or assistant. Situation awareness leads to decision making. Back to Wisperlingham. He made a report of his work, as I am sure all of us would have to do. But his report received little notice by the medical department. However, the Perak resident, George Maxwell, took notice. Sometimes they are good politicians. The point is communication. Sometimes I wonder if the fact that Arumugam was an Asian robbed him of more recognition as in the medical world then. But fame is always fickle, and many other discoverers of medical breakthroughs have been buried without notice. But the key is communication. Some people become more famous because they communicate well. But communication is not just about becoming famous. Good communication within the operating theatre is vital, not to be famous, but to save lives. That is why we have to have checklists and timeout. There is a whole lot about how we communicate in the NOTS course. In Wisperlingham's case, it meant him succeeding in mounting a systematic campaign for the eradication of yaws in the Federated Malay States. Over 9 years from 1921, about 13,000 to 31,000 cases of yaws were treated each year. Although it reduced the prevalence greatly, it did not cover the whole country, and with the setback of the Second World War, yaws emerged again as a prevalent disease among rural Malays. After the war, the Director of Medical Service remarked that in some parts of the country, particularly in the East Coast, almost every child was affected. The introduction of procaine penicillin dramatically changed the prospects of yaws eradication. It made only one injection necessary. Between 1954 and 1963, the Malayan government, with the assistance of the WHO, carried out the yaws elimination campaign. And at the peak, a total of 104,000 cases were treated in 1948. By 1963, the incidence rates had dropped to less than 0.5 in the population in all. The last area we discussed in NOTS is leadership, and that is the harder thing to encapsulate. There's a team working in every operating theatre, and the surgeon has to lead the team by example, by instruction, and by encouragement. We get opportunities to lead sometimes and sometimes not. Let me continue with Wisperlingham's story. He was transferred to Kuala Pilah without any recognition of his work on yaws. He next applied for sabbatical leave, hoping to pursue studies in Europe, but instead, he was allowed to enroll and specialize in ophthalmology in Madras. He also took a 3-month course in obstetrics and gynecology. On his return the next year, he was ordered to organize the ophthalmic work in Kuala Lumpur. In 1930, he applied and obtained approval for sabbatical to study in Vienna and studied ear, nose, and throat diseases. On his return the next year, he was asked to include ENT work. Wisperlingham stayed faithful at his post in Kuala Lumpur when the Japanese invaded. He refused to work for the Japanese and became destitute, and the Christian Brothers at St. John's Institution offered his family shelter. When the British returned, Wisperlingham immediately rejoined the medical services and set about reconstructing the eye department in Kuala Lumpur. Again, officials dealt him a raw deal. He had reached the prescribed age for retirement, and he was not allowed to extend his service, and he described this as having ashes in his mouth. In retirement, He did some private practice, but he left in 1951 for Sri Lanka. He practiced in Colombo and became president of the Ceylon Ophthalmological Society, founder president of the National Association of the Prevention of Blindness, and was honorary member of the International Agency for the Prevention of Blindness. Arumugam Viswalingam left a legacy of no more yaws in Malaysia and an ophthalmologic service that has grown. I don't know much about the Sri Lankan Association for the Prevention of Blindness or the Ophthalmological Society here to remark on them. But I think that is quite a legacy of leadership to leave behind. I want to say a few words now about leadership, especially in the context of knots. Since it is in the context of the operating theatre and preventing behavioral errors, there we focus on a narrow concept of leadership. And there are three elements to it, namely maintaining high standards, supporting others, and coping with pressure. I would have to give you the knots lecture to explain all that. But leadership is that behavior that puts priority in what is needed most. For example, foregoing some relaxation or meeting when you are needed in the OT, scrubbing in when your trainee needs you, and support and keeping calm so that others can focus on the work. Let me conclude by coming back to the knots course. I've outlined for you the behavioral skills that analysis shows will make a difference in our fight against adverse events in the operating theatre. It is not a series of talks to listen to that we forget. It includes learning how to score behavioral elements and observing them in a systematic way in order to put them into practice regularly, both as an individual and at a team level. And studies have shown that adverse events do come down when surgeons put this into practice. We have been rolling knots out in Malaysia, and we are in partnership with the Royal College of Surgeons of Edinburgh. And the effect has been positive. We hope the long-term effects will manifest themselves also. I would welcome questions for those of you who might be interested. Thank you.
Professor Lim, we have a few minutes. May I invite you to join me here? And if you can.
I'll be happy to take some questions.
Or you can just add
a few remarks.
Can I get you to remove the mask for here?
With us at this conference have been the delegates from Edinburgh, and actually they'd be wonderful people to ask some more if you'd like to run a knots course. I think they say they will be willing to come. Over in Malaysia also, we like to offer our help if we can. For example, if you come for our conference next year and we run a knots course as a pre or post congress, do join in. One thing I would like to say about rolling out knots, the success I think in Sri Lanka would be if you make it part of the training requirements, then automatically all your trainees will be motivated to come. And perhaps I added one extra note. Viswalingam, Arumugam Viswalingam did leave his elder children behind in Malaysia when he came back to Sri Lanka. And just to let you know, his daughter married somebody named Shanmugaratnam, who happened to be a very distinguished doctor in Singapore. And his son was named Thanam. And if you put that two together, you know who that is. Thanam Shanmugaratnam, Deputy Prime Minister in Singapore, is the grandson of Arumugam Viswalingam.
Thank you very much, Professor Lim Keen Gee, for your descriptive and inspirational lecture.
Thank you.